Assalamu alaikum warahmatullahi wabarakatuh. To continue the development of the heart, I'm going to discuss in this presentation the heart anomalies. I'm Dr. Dalia Saleh, Professor and the Head of Anatomy Department at Mansoura University, Egypt. The congenital anomalies of the heart can be divided into the following. Anomalies arise during the formation of the heart loop. Anomalies arise during the formation of the interatrial septum. Anomalies arise during the formation of the interventricular septum. Anomalies related to the division of the Atrio-Ventricular Canal. And finally, anomalies related to the division of the outflow part of the heart. Let me remind you first of how the heart loop is formed. This is the heart tube made of the following parts. The inflow part is called the sinus venosus, which leads to the atrial swelling, then to the ventricular swelling, then to the bulbous cordis, and then the blood leaves the heart through the outflow part of the heart. This circle represents the pericardial space or pericardial cavity. During development, the heart tube elongates, so the heart tube is forced to bend upon itself. So the heart loop is now looks like the letter S with a left limb, a right limb, and a horizontal part connecting them together. The right limb is formed by the Truncus Arteriosus and bulbous cordis. The transverse limb is formed by the ventricular swelling, and the left limb is formed by the atrial swelling and the sinus venosus. With more and more bending of the heart, now the atrial swelling moves upward and behind the two ventricular and bulbous cordis swelling, and the Truncus Arteriosus come in the middle. Abnormality in formation of the heart loop will lead to abnormality in heart position. This is the normal anatomical position of the heart. This is the midline, and the heart is slightly shifted to the left of the midline. If there is abnormality or reversal of the formation of the heart loop, the heart will be located on the right side of the chest. We call this anomaly dextrocardia. This can be a separate anomaly, as we can see in this X-ray. Only the apex of the heart is directed to the right side of the chest instead of being on the left side. If you look under the left copula of the diaphragm, you can see a gas stomach. This means that the rest of the viscera are in their normal position. This anomaly could also be associated with other organ transposition. In this case, we call it situs inversus, where all organs are reversed in their position. So in this X-ray, you can see on the right side the apex of the heart, means that there is dextrocardia, and also you can see gases under the right copula of the diaphragm. This means that the stomach is also on the right side, and the liver here is on the left side. If there is a thoracic wall defect, the heart may be exposed to the outside. We call this anomaly ectopia cordis. So in this picture, you can see this. There is a large defect in the chest wall, and the heart is protruding to the outside. Now, let me remind you of how the interatrial septum is formed. So in this diagram, you can see the common atria and the common ventricle, and in between them lies the Atrio-Ventricular Canal, and here you can see the septum intermedium. And the AV canal is divided into right side and left side. This is the sinus venosus, and this is the sinoatrial orifice. The first appearance of the interatrial septum is through this thin membrane, which is called septum premium. It looks like a letter C. It grows downwards towards the septum intermedium, but it leaves a foramen below it. We call it ostium premium. When the septum premium grows downwards towards the septum intermedium, the ostium premium gets smaller in size, but in the same time another ostium or foramen appears at its upper part. We call it ostium secundum. When septum premium grows downward and finally manages to close up the ostium premium, the ostium secundum gets enlarged. Then another septum appears to the right side of the septum premium. We call it the septum secundum. This septum grows and try to cover the ostium secundum. However, there will be an oblique passage between the two septa, septum premium and septum secundum, where blood can pass through this opening from the right atrium to the left atrium. We call this oblique passage the foramen ovale. Later on, the septum premium degenerates and acts as a flap or a valve that controls the passage of the blood in this foramen. So blood pushes this septum or this valve and passes from the right atrium to the left atrium. Regarding the anomalies of the interatrial septum, either there is no development of the interatrial septum at all. In this case, we end up with trilocular heart, or there is abnormality in formation of the septum premium, so we get persistent foramen premium, or there is abnormality in formation of the septum secundum, so we end up with a common anomaly which is called persistent foramen secundum, or if there is abnormality in fusion of both septum premium and secundum together, so we end up with persistent foramen ovale. This could be an anatomical defect. In this case, we call it propatency foramen ovale, where there is anatomical communication between the right and the left atria, but there is no mix of blood. Or it could be a functional defect. In this case, we call it patent foramen ovale, where blood can pass from one chamber to the other. Or we could have a premature closure of the foramen ovale during intrauterine life, and this is a fatal condition for the fetus. So in this case, both septum premium and the secundum fail to develop, and the heart now is formed of one common atrium and the two ventricles. So we call this anomaly trilocular biventricular heart. When septum premium fails to fuse with the septum intermedium, we end up with persistent foramen premium. When septum secundum fails to develop, or when there is excess degeneration of septum premium, we end up with persistent foramen secundum. Anomalies related to the persistence of foramen ovale arise when septum premium and the secundum fail to fuse together. So this persistent foramen ovale could be an anatomical defect, just there is an anatomical passage between the two atria, but there is no shunt of blood from right to left. Or the persistent foramen ovale could be functional when there is shift of blood or shunt of blood. Now, how the interventricular septum develops? If you remember, it develops by a different mechanism than that of the interatrial septum. The muscular part of the interventricular septum develops when there is expansion of the two ventricles and opposition of their medial walls together. Above the muscular part of the interventricular septum, a foramen lies there. It is called the interventricular foramen. It will persist till there is completion of septation of the outflow part of the heart, and this foramen will be closed up by a membrane. So if there is no development of the interventricular septum at all, we end up with the trilocular heart. Or if there is abnormality in the formation of the muscular part of the septum, we end up with ventricular septal defect, which could be single or multiple at different sites. Or if there is abnormality in formation of the membranous part of the septum, we end up with what is called persistent interventricular foramen. In this case, both muscular and membranous septa fail to develop, so we end up with trilocular heart. Now the heart is formed of two atria and a single common ventricle, so we call it trilocular biatrial. Ventricular septal defect, or VSD, is a defect in the muscular part of the interventricular septum. It could be single or multiple at different locations of the septum, and oxygenated blood will move from the area of high pressure, meaning that from the left ventricle to that of the right ventricle. The blood that will be added to the right ventricle may lead later on to pulmonary hypertension and increase in the pressure in the right side of the heart, and the shunt could be reversed if the pressure in the right ventricle exceeds that of the left ventricle. That's why we call it a potentially cyanotic heart disease. If the membranous part of the interventricular septum fails to develop or fails to fuse with the muscular part of the interventricular septum, we will end up with persistent interventricular foramen. And this results from either lack of formation of pulpar ridges or abnormality of the endocardial cushions that divide the AV canal. So you can see in this animation how the blood flows through this defect in the membranous part of the interventricular septum. And you can see that blood moves from the chamber of the highest pressure, which is the left ventricle, to that of the right ventricle. So mixed blood will be on the right ventricle and pushed to the pulmonary trunk, and this may cause pulmonary hypertension. Note that the oxygenated blood is in red, the non-oxygenated blood is in blue, and the mixed blood is in purple. Now, let's talk about the division of the Atrio-Ventricular Canal. Remember that we have two cushions, inferior and superior endocardial cushions, that appear at the wall of the AV canal. These cushions will grow towards each other and meet in the middle and form the septum intermedium. Thus, the AV canal is now divided by the septum intermedium into right AV canal and left AV canal. And the blood can pass from the common atrium through these two AV canals to the ventricle and then leaves the heart through the outflow part, or the Truncus Arteriosus. So the anomalies of the AV canal partitioning or septation could be either there is no partitioning at all, and in this case we end up with persistent AV canal. If there is unequal partitioning, we will end up with narrowing of one of the valves opening, we call it stenosis, and widening of the other valve opening, we call it incompetence. Other anomalies related to the AV canal could be fusion of the cusps of the valves, we call it valve atresia. In this section we can see how the two endocardial cushions grow and fuse in the midline and form the septum intermedium. If this doesn't occur and the septum intermedium fails to develop, we will end up with what is called persistent atrio-ventricular canal. The single AV canal will be associated with interatrial septal defect and also with interventricular septal defect. Let's assume this is the AV canal and this is the septum intermedium. So there is equal division of the AV canal into tricuspid opening and mitral opening. As we can see in this picture, you can see that the blood flows from the right atrium to the right ventricle through the tricuspid opening. Let's assume that the septum intermedium is deviated to the right side. So we will end up with tricuspid stenosis and mitral regurgitation. So in this picture, you can see that there is stenosis in the tricuspid valve, and the amount of blood flows from the right atrium to the right ventricle is altered. Again, this is the AV canal and this is the septum intermedium. And in this picture, you can see the right ventricle during systole. The blood is pushed from the right ventricle to the pulmonary trunk, and there is closure of the tricuspid valve, and there is no regurgitation of the blood back to the right atrium. So let's assume that the septum intermedium is deviated to the left side. So we will end up with tricuspid regurgitation and mitral stenosis. So you can see in this picture that tricuspid regurgitation during systole, the blood passes from the right ventricle to the pulmonary trunk, and at the same time part of it regurgitates back to the right atrium because of the incompetent tricuspid valve. Finally, we'll talk about the Truncus Arteriosus, division and anomalies. You can see here that Truncus Arteriosus is divided by the two ridges that arise in their wall. They crisscross and move around each other in a spiral way and move downward to fuse with both septum intermedium and the muscular part of the interventricular septum. So we end up with two big vessels in the Truncus Arteriosus, the pulmonary trunk and the aorta. And you can see how they twist around each other because of the spiral aorticopulmonary septum. If there is no development of this septum at all, so we will end up with persistent Truncus Arteriosus. If the septum is not spiral or straight, then we will end up with an anomaly called the transposition of the great vessels. If there is unequal division of the Truncus Arteriosus, we will end up with an anomaly. It's called phallus tetralogy or tetralogy of Fallot. The persistent Truncus Arteriosus arises when there is no development of the aorticopulmonary septum, so we end up with a single arterial trunk and a membranous VSD, and because of that, the oxygenated blood will mix with the non-oxygenated blood through this defect, and the tissue will receive a less oxygenated blood. In this anomaly, the aorticopulmonary septum grows in a non-spiral way or in a straight way. So the aorta will arise from the right ventricle and the pulmonary trunk will arise from the left ventricle. It is associated with other anomalies as atrial septal defect and ventricular septal defect, and it is a cyanotic heart disease because there will be mix of non-oxygenated blood with the oxygenated blood. Tetralogy of Fallot is a mix of anomalies made of 4 components: VSD, pulmonary stenosis, right ventricular hypertrophy, and overriding of the aorta. So the aorta arises from both right and left ventricles. You can see that there is a mix of blood between the right ventricle and the left ventricle because of the VSD. And because of the right-sided hypertrophy, the non-oxygenated blood will move from the right ventricle to the left ventricle. So the blood that will reach the aorta and the rest of the tissue will be less oxygenated. So it is a cyanotic heart disease. Anomalies related to the semilunar valves, meaning that the aortic and pulmonary valves. You know that these valves are guarded with cusps. During systole, these cusps will open up and blood will leave the ventricle into these arteries. So in this case, we can see that the blood leaves the right ventricle through the pulmonary valve to the pulmonary trunk. If there is partial fusion of the cusps of the valve, we will end up with what is called valve stenosis. You can see that the amount of the blood that passes through the pulmonary trunk is less than that of the normal amount. But if there is complete fusion of the cusps, we will end up with what is called valve atresia. This is the end of my presentation. Thanks for listening, and if you like it, please do not forget to subscribe, like, and share.